and welcome you all. And it is my proud privilege to welcome each one who is joined together on this platform of ISAR Haryana with our motto of Prayas Evam Vistar, and I'm Dr. Jyoti Malik. Today, actually, we are starting with another series, Up to Date with Updates. And it is something unique that we ISAR Haryana people have brought on this platform, where we would be talking every month, every fourth Tuesday of every month, and we would be taking an article from our latest fertility sterility journal, and we would be discussing that with an expert, a think tank of ISAR. And actually, I really feel indebted and feel privileged that we have our president, Dr. Ameet Patki, sir, who was convinced with this idea, and he suggested so many names, and that is how we have these think tanks of ISAR, Dr. Ameet Patki, sir, the president himself of National ISAR, Dr. Nandita Palshetkar, the immediate past president, Dr. Madhuri Patil, vice president, Dr. Sujata Kar, vice president, Dr. Asha Baxi, secretary general, Dr. Charudutt, Joshi, chairperson for embryology, and Dr. Keshav vice chairperson for embryology. So every time one of these experts would be guiding us on this platform. And another new thing that we have, the idea that Sir himself suggested that we should be doing it with ISAR Brigade. So ISAR Brigade is the national brigade where we have these youngsters who would be sort of joining us, putting in their sort of inputs, and also we would be taking they would be also sort of giving their we would be asking them questions. So the expert would be mediating, and we would have one particular expert from our national ISAR. So that is why we have named it as Up to Date with Updates, so that we update ourselves with the latest articles or with the latest guidelines and the journals. So this is the motto of this series that we intend to bring every month. So with this, I would invite my team ISAR Haryana. We have our secretary, Dr. Meenu Handa, clinical secretary, Dr. Manju Dagar, and treasurer, Dr. Lakshmi Goyal, who all are behind this. And I now invite Dr. Meenu Handa to please introduce our national president, Dr. Ameet Patki, sir.
So a very warm welcome to everybody. And it's my great honor and pleasure to welcome Dr. Ameet Patki, sir, our very dynamic and a very warm ISAR president. Sir is the medical director for Fertility Associates in Mumbai, and honorary associate and Professor K.G. Somaya Medical College and Hospital. Sir is also the consultant at Khar Hinduja and Surya Hospitals in Mumbai. Country representative, Aspire 2021-2023. Governing Council member, ICOG from 2012 to 2021. And current president ISAR, General Secretary MSR 2018 to 21. Chair of West Zone RCOG 2015 to 2020. President MOGS 2014 to 15. Sirs also has the publications, 35 publications in national and international journals, and more than 50 book chapters and editors of 3 books. Sir's got 2 international patents in infertility and stem cell research, and also a very celebrated TEDx speaker. We welcome you, Dr. Ameet Patki, sir, and please enlighten us with your warm words.
Thank you very much. At the onset, I must congratulate Haryana ISAR, led by Dr. Jyoti Malik and assisted ably by Dr. Meenu Handa and team, for always being in the forefront as far as academics was concerned. Haryana ISAR was the first one to conduct a ISAR program in my presidency. And I think you all have also come up with a fantastic idea of discussing good articles and having experts like Dr. Sujata on the team who will then discuss that paper. I also appreciate your willingness to include the ISAR Youth Brigade, because I think they are our future and we need to create a good second line to take over from us. So I would like to wish you all great success, and Jagsonpal Pharmaceuticals, who are so willingly, who have offered the platform to conduct these webinars. The topic of AMH, PCOS, and prediction of ovulation is a fantastic paper. I have gone through this paper and I think it's very innovative idea of using AMH for predictive purposes in ovulation induction by use of two common medications, clomiphene and metformin. So without wasting much time, I would like you all to take this ahead, and I'm sure we'll have excellent, healthy discussions and many more sessions in the future. So thank you once again, Haryana, ISAR, and congratulations to you all for this very innovative webinar. Thank you.
Thank you so much, sir. Thank you. Your support, your blessings, and always are there. And that is why we feel so enthusiastic doing something new every time. Thank you, sir. We would like to introduce our expert first. None other than Dr. Sujata Kar, my favorite, our Vice President, National Vice President of our ISAR. And ma'am is doing endoscopy and ART for last 27 years. And her area of interest is polycystic ovary syndrome, proteomics of male infertility, and scope of stem cells in gynecology. Her major achievements have been 7 gold medals in MBBS, credited with the first IVF baby of Eastern Orissa, first TSA, frozen embryo, laser hatch babies of Orissa. She has been awarded the Parichya Award of Women Achiever Orissa 2019 by the Honorary Governor of Orissa, Devi Awards for Dynamism from CM Orissa, and Brand Icon Excellence Award 18 for Best IVF Center in Eastern Asia. Not only this, she has multiple publications. She is a thorough academic person, and publications, 15 publications original related to PCOS and male infertility in PubMed, and many chapters in various books, newsletters, and review of many journals. Dr. Madhumitha is our ISAR Brigade person, and she is also a treasurer of Salim chapter of TAPISAR. She is editor of the newsletter of Midlife Management Committee of FOGSI, and organizing treasurer of the Yuva FOGSI South Zone 2022. She is also the cultural secretary of Yuva FOGSI South Zone 2022 and assistant coordinator of online ART courses of American Center of Reproductive Medicine Cleveland Clinic. And she has multiple awards, and she is Miss FOGSI 2023, FOGSI Superstar Award of the South Zone in Dance, and international publications also goes in her credit. Then we have Dr. Shruti Namdev Mane. She is IVF consultant at Motherhood Hospital, Navi Mumbai, and she is also a committee member of Indian Academy of Vaginal Aesthetics and Functional Gynecology for year 24-25, won third prize for paper presentation, a spectrum of obstetric emergencies in day-to-day obstetrics in Bombay Medical Congress conducted by INHS, Ashwini, and won second prize for her poster presentation on study of teenage pregnancy and outcomes. So welcome, Dr. Madhumitha and Dr. Shruti. Right away now we start with our, we have Dr. Sujata, who would be guiding us once I go through this paper. And as Dr. Ameet sir has already suggested to us that we would be talking on the anti-Mullerian hormone level predicts ovulation in women with polycystic ovary syndrome treated with clomiphene and metformin. So this is from the Fertility Sterility Journal, April 2024. So it is just the latest paper that we could get our hands on, and it is very practical also. So that is why it interested us, that we should talk on something very practical, which we normally do in our day-to-day practices. So the objective of this study that was done was to describe the serum AMH concentrations in a large, well-phenotyped cohort of women with polycystic ovarian syndrome and evaluate whether AMH predicts successful ovulation induction in women treated with clomiphene and metformin. It is a randomized controlled trial, and we all understand what PCOS is, and individuals with PCOS often experience oligo-ovulation and ovulation, and the criteria often used for diagnosing PCOS is increased antral follicle count or increased ovarian volume on ultrasound. Now, AMH is a dimeric glycoprotein, which is part of the transforming growth factor beta family and is produced by the granulosa cell of the pre-antral and the antral follicles. And it is not currently a diagnostic criteria for PCOS, though several studies suggest that it could serve as a proxy for antral follicle count. Now, AMH criteria for PCOS, the most recently published international guidelines for PCOS recommend including AMH in the evaluation of ovulation and in the diagnostic criteria. No clear-cut AMH cutoff values have been established because of limited data on the AMH values in individuals with PCOS, as well as variation among the various assays that have been used to assess AMH and also by age. And excess of AMH may be harmful to the process of folliculogenesis and may be involved in the cessation of follicular growth occurring in the ovaries affected by PCOS. There is evidence that high AMH can be associated with resistance to clomiphene and letrozole, the common ovulation induction treatments that we normally use in our practices. Now, primary objective of this study was to expand the published data on the AMH values in well-phenotyped PCOS and to evaluate whether the serum AMH predicted the success of ovulation induction treatments in women with PCOS. And women here were randomly assigned. So there were 3 groups. One was only clomiphene, where clomiphene was used. The second group where clomiphene plus metformin was given. And the third was only metformin alone. And we hypothesized that a higher baseline serum AMH would be associated with a reduced odds of ovulation in all the treatment groups. So the material and methods, the data in the study was used from the pregnancy in polycystic ovary syndrome. That is the PCOS-1 trial. And the study design, the use of infertility screening, power analysis, and initial findings of this study have been described previously. This was a RCT conducted at 12 centers in the United States, and it was registered on the clinicaltrials.gov. And all the participants gave a written informed consent, and the study was approved by the institutional review board at each center. Now, the progesterone levels were measured weekly or every other week, and treatment was continued till the participant had either a positive pregnancy result or completed 6 cycles of treatment. Serum and plasma from the study participants was stored at -80 degrees centigrade from initial recruitment until batched analysis was performed in 2021. And the analysis was in this study, AMH was assessed for available stored baseline serum samples, which were collected in the early follicular phase of the participants' menstrual cycles. And this was calculated using an ELISA, and this is the exact the machine that this was used for the analysis. Now, inclusion and exclusion criteria for this was, now there was 626 women with infertility and PCOS were enrolled in this study. The inclusion criteria were oligomenorrhea, increased testosterone levels, those seeking pregnancy with a normal uterine cavity with one or more patent fallopian tubes, and a partner who had a recent semen analysis with sperm levels of more than 20 million per ml. And so the baseline evaluation included the fasting serum testosterone, sex hormone binding globulin, pro-insulin, insulin, and glucose. Standardized interviewer-administered questionnaires elicited the history, the medical history, obstetric, gynec, infertility history, smoking status, family history, and other demographics. Biometric evaluation included the height, weight, BMI, waist circumference, and the hirsutism score was calculated by the modified Ferryman-Galway method. A transvaginal ultrasound was performed to assess the polycystic morphology and the ovarian volume. And ultrasound information was not included in the PCOS diagnostic criteria in this study because this study was initiated before the publication of the Rotterdam criteria. And participants were then randomly assigned to one of the treatment arms, metformin, clomiphene citrate, or both. Progesterone levels were measured weekly. The pregnant treatment was continued till a positive pregnancy test or till 6 cycles of treatment. And the serum was stored at -80 from the initial recruitment till the batch analysis. And all this was collected in the early follicular phase of the cycle. So the assay had a linear double-sided antibody that had epitope in the N-terminus of AMH, and the sensitivity of this assay was 0.029 nanogram per ml, with the inter-assay coefficient of variation 3.2% and 2.4% at 1.5 and 3.3 nanograms per ml. The baseline serum samples were obtained only for 333 out of the 626 women enrolled in the trial. And data from these participants were presented in the following. AMH concentration was unable to be obtained for 11, of which 8 samples were missing appropriate labeling, and 3 had insufficient serum available to complete the AMH testing. The main outcome was of this analysis was whether ovulation had occurred or not, depending on the AMH levels, and it was confirmed by doing the progesterone concentration if it was more than 5 nanogram per ml. So also the secondary outcome was finding out a fetal heart on a transvaginal ultrasound or a live birth, that means the delivery of a viable infant. Also, it was sought to establish an optimal threshold of AMH concentration that predicted ovulation and to identify any independent predictors of ovulation through logistic regression modeling. And all these analyses were conducted using a R statistical software version 4.1.2. Now, descriptive statistics, including the mean standard deviation and count, were used to report the participant characteristics. And given the international standards for AMH values do not exist, participants were compared by tertile of the baseline AMH and divided into 3 clinical categories on the basis of the baseline AMH. So they divided it into with people, with the women who had AMH less than 4, between 4 to 8, and more than 8 nanogram, per ml. Now, AMH of less than 4 is normally considered normal. So although there is not a currently AMH concentration diagnostic of PCOS, but previous meta-analysis had identified a cutoff AMH values of 4.7 and 4.9 as sensitive and specific, and therefore they took up a AMH concentration less than 4 as a normal. AMH of 4 to 8 was chosen as the intermediate category, and AMH of more than 8 was selected as the highest category. And this cutoff was determined on the basis of a previous study that found that AMH threshold of 7.7 nanogram as predictive of ovulation with clomiphene ovulation induction in women with PCOS. So a logistic regression model to model the association between baseline AMH and these three outcomes, ovulation, pregnancy, and live birth, was used, and this was modeled as continuous, as tertiles, and as the clinical categories. And so because the original PCOS study found a difference in outcomes by treatment group with higher live birth rate in clomiphene and clomiphene plus metformin group than in the metformin alone group, we adjusted for treatment group in our analysis. So all these AMI, BMI, race, ethnicity, waist to hip ratio, hirsutism, LH levels, total testosterone, insulin sensitivity, androgen index, combined ovarian volume, PCOS morphology, duration of treatment, infertility diagnosis, history of pregnancy, smoking status, they were individually evaluated as possible confounders in regression models, and all these as it has an association between AMH concentrations. So a receiver operating curve was used to identify an optimal threshold of the AMH predicting ovulation. So the results were as follows. Out of these 333 women where the baseline serum was available, of the 626 women enrolled in the study, 124 participants were randomized to ovulation induction with clomiphene alone, 124 to clomiphene and metformin, and 85 participants to metformin alone. And the demographic characteristics as are shown by AMH category in table 1. So we'll come to this table, and the three treatment arms were similar with respect to all the characteristics, with the exception of the smoking status. So this was a little peculiar because the proportion of current smokers in the clomiphene in the metformin alone group. So this was a little different. So this is the table 1 where they have the patient characteristics are here divided according to the treatment, the age, the BMI, the waist circumference, waist hip ratio, ethnicity, race, ultrasonographic findings, the pheromone score, the baseline fasting serum, insulin, pro-insulin glucose, LH, SHBG, total testosterone, FAI, and HOMA score. And the other characteristics, the previous diagnosis of infertility, previous history of pregnancy, smoking status was also taken into consideration. And these were the three categories of AMH: less than 4, 4 to 8, and more than 8. And according to this, it was now out of this, we've already spoken that the AMH was received only in 322 participants, and among these the baseline AMH was 11.7 with a standard deviation of 8.3, stratified by clinical baseline AMH. 39, 90, and 193 individuals had the AMH less than 4, 4 to 8, and more than 8. So 193 individuals had AMH more than 8, nearly 40 had less than 4, and 90 had between 4 to 8. So they also found that the women who ovulated had a slightly lower BMI, waist circumference, insulin, pro-insulin, and HOMA score than those who did not ovulate. And another very typical finding was that women who ovulated were also slightly older on the average. So in the unadjusted analysis, the baseline AMH concentration was significantly associated with odds of ovulation with ovulation induction during the study period. And for each unit increase in the baseline AMH, the odds of ovulation decreased by 8%. So this is something very, even with 1 unit AMH rise, the odds of ovulation is decreasing by as much as 8%. Comparison of AMH concentration among those who ovulated and did not ovulate, we'll come to these figures. No maximum AMH was noted above which no participants ovulated. And a sub-analysis of those who ovulated demonstrated that those who ovulated after 2 cycles of treatment had a baseline around 2.2 nanogram greater than those who ovulated in the first cycle. No significant association was noted between baseline AMH and clinical pregnancy or live birth rate. Treatment group was not a significant effect modifier of the association between baseline AMH and ovulation, clinical pregnancy, or live birth. Race was not noted to be a significant effect modifier of the association between baseline AMH and ovulation. However, BMI was a significant effect modifier of the association. So this is the box depicting. So this red is no ovulation, and this blue is the ovulation. So, and this is the AMH levels. So as the AMH is increasing, the no ovulation, this box has increased. And at lower AMH level, this was the ovulation that was occurring. This was by the AMH concentration. This plot, the box plot depicts no ovulation in the red and ovulation in blue by AMH in the 3 treatment groups. So one was only clomiphene, one was clomiphene with metformin, and this was metformin alone. And again, this was the AMH concentration categories and association with ovulation. So in this, the baseline AMH, when it depending on the number of participants here, the unadjusted and then unadjusted OR for ovulation, OR for ovulation adjusted for the treatment, and adjusted for the potential confounders. So Dr. Sujata ma'am, here I would like you to explain to us how we should understand predicting this. How would we interpret, I mean, an unadjusted for and or for ovulation adjusted and for the potential confounders? How should we understand, what should we take, because I was not able to get much of...
so I am also not great in statistics.
Yeah.
It's difficult for me also to understand. Basically, odds ratio was, you were asking, for example, this says that number of less than, these are the 3 categories. They are saying unadjusted odds ratio for ovulation. So unadjusted odds ratio means, I understand, is that without you are adjusting the confounding factors, which means taking into account the BMI, taking into account age, other things which might impact ovulation. Odds ratio for ovulation adjusted for treatment arm, odds for ovulation adjusted for potential confounder. So once you've taken into account the fact that age, BMI, baseline, HOMA IR, insulin resistance, etc. can affect, once you have taken that into account, then these are the odds of ovulating. So which means that
when ma'am, here they have adjusted, so it is coming to be 0.9. When it was odds ratio for ovulation adjusted for treatment arm, it was 0.76, and unadjusted it was 0.75. So what does it make? I mean, we have to understand.
We have to ask the statisticians. Extremely poor in understanding the statistics. You know, we have to, as clinicians, we have to look. But then I'm sure the younger people. Let's ask whether the youth brigade, those
Madhumitha
people who have if ever they have published, because the younger people are now all studying statistics a lot, even whether in their MBBS or otherwise.
So that we can understand what these articles are telling us by these by their statistics. Madhumitha, do you understand what we are trying? I mean, what does this chart really tell us? Can you explain to us, Madhumitha?
Basically, one thing that I understand is the p-value here for greater than 8 nanogram, and after the odds ratio has been adjusted, here the last right bottom here we get the p-value is p is equal to 0.008. So that means this is of significance.
Statistically significant.
The others, all the p-value is more, so others are not statistically significant. So after it has been all the confounders, it's all been all the bias has been removed. If the AMH is greater than 8 nanogram per ml, then that means for people with AMH greater than 8, there was a significant, statistically significant reduction in the ovulation.
Yeah, but even if 0.05 is the cutoff, I mean p-value that you're taking as significant, then at all levels it's significant. Right? 0.05? Then 0.01 is less than 0.05.
0.05, yes.
Each one is still significant.
Significant.
So I feel personally, Jyoti, although you are absolutely right in trying to discuss this, but as clinicians, we will probably benefit more from clinical discussion. But yes, all of us should have working knowledge of statistics.
Yeah. So maybe next time we will also include some statisticians, so that we can learn it and we can understand it better, ma'am, that way.
Agreed. Absolutely agreed. Yeah. Next time we do that.
Because I was not able to understand all this. I was just reading those lines and was understanding the basics of it, but I was not able to understand what sense these tables made to me. So that is why I thought maybe we can next time we can also
include a statistician.
Yes.
But so statistics is also very, very tricky. You know, you need to know what statistics to calculate for what kind of study. And I think you are right. Maybe a statistician we can try, and it might help us understand quite a lot.
Because even this I was not able to understand, ma'am. The percentile, I understand percentile, but what this tertile is, because they said AMH concentration by tertile. So, and association with ovulation. So again, I was at a loss to explain this table. I have put this table, but I have no clue what it makes. So Shruti, do you have any idea? We can ask Shruti also if she has any knowledge. Shruti, can you understand this table or no?
Ma'am, as compared to the last table, here it is showing that when the baseline AMH is more than 12.9, so the ovulation, the odds ratio which is adjusted for ovulation in the treatment arm with clomiphene and for with adjusting the other confounding factors, with taking into consideration the other confounding factors, it was statistically significant when it is more than 12.9. So in all the three arms, it's statistically significant.
Okay.
So tertile is basically 1/3 of the total, ma'am. So here we have divided into 1/3. Like here they've given less than 7, 7 to 13, more than 13. So tertile is basically 1/3, 1/3, 1/3.
Okay, I see. All right. Because I was right. So we can have a better idea in the next paper that we go through.
Yes.
Yeah. So then in the discussion, we had So this is clinical. So this is simple to understand. Now, in women with anovulatory infertility in PCOS, we found that there was a higher baseline AMH concentration, which was associated with reduced odds of ovulation with OI treatment, regardless of the treatment method. Either it could be anything, clomiphene, clomiphene plus metformin, or metformin, but whenever there was a higher baseline, there was always a reduced odds of ovulation. So this is the basic thing that they have sort of concluded. Now, each unit increase in the AMH concentration was associated with a 10% reduction in odds of ovulation in our adjusted analysis. Women with AMH more than 8 were significantly less likely to ovulate compared with those with a normal AMH of less than 4. This difference persisted when adjusted for both the ovulation induction agent and the confounders associated with ovulation, suggesting that the AMH concentration is a critical predictor of whether a patient is PCOS-related infertility will achieve ovulation with ovulation induction. Other independent predictors of odds of ovulation with OI in our study included BMI and the baseline HOMA score, with both having an inverse association with odds of ovulation. But we did not find an association between hyperandrogenism as measured by Feliman, Galway hirsutism score, total testosterone, or free androgen index and odds of ovulation. So we noted that the relationship between the baseline AMH and ovulation was dependent on BMI, with predicted probability of ovulation declining more steeply by AMH level in women with a higher BMI. No association between baseline AMH concentration and pregnancy or live birth rates was noted in our cohort. So basically, they have BMI and the HOMA score. These two things they say in their study had an inverse association with odds of ovulation. They also have compared with various other studies. One was this Mumford et al., where there was another randomized clinical trial with good number of 748 women, and found that a lower mean AMH concentration among women who ovulated with ovulation induction with clomiphene or letrozole. So in this study, they also had letrozole included. In their analysis, each unit increase in AMH was associated with a 6% reduction in the odds of ovulation, compared with our finding of a 10% reduction with each unit increase in the AMH. Interestingly, the baseline AMH concentration in our study was higher than that of the women in the PCOS 2 trial, with our mean AMH being 11.7, whereas the fourth quartile of AMH in the PCOS 2 was more than 10.23. Another prospective study by Z et al., where 81 anovulatory women were treated with clomiphene, it was found that AMH concentration independently predicted ovulation, with a threshold AMH of 7.7 identified using a receiver operating curve, whereas we identified a threshold concentration of 11.18 as the predictor of ovulation. So this suggests that our study included women with a more severe PCOS phenotype, or that modern AMH assays were trending towards higher values. In contrast, Sachdeva et al. Found in their prospective observational study of 164 women with PCOS-related infertility treated with clomiphene that the Ferriman-Galloway score was the best predictor of non-responsiveness of clomiphene treatment, and androstenedione was another independent predictor. In our analysis, the Ferriman score and biochemical hyperandrogenism by total testosterone and free androgen index were not associated with the odds of ovulation, and this discrepancy could be because of the addition of metformin in our study. And most participants were treated with either combination with clomiphene and metformin or metformin alone. And moreover, our study consisted of a larger study population with randomization to induction treatment. So strength of this study was, it was a large study population, more than 300 individuals, well characterized with respect to the diagnosis, including demographics, biomarkers, and ultrasonographic data. It was a randomized trial. Baseline testing was similar between the 3 treatment arms. Participants were monitored prospectively throughout their participation with frequent measurements of the serum progesterone concentrations, providing accurate assessment of the ovulation. The limitation of this study was that the baseline samples for the analysis were available for only 333 of the 626. So nearly half of the participants that were there, only they could take only half of the serum samples. However, this subgroup had similar outcomes with ovulation induction treatment as the original trial, and therefore likely is a representative sample of the original study population. Additionally, the serum samples had been stored for several years before AMH concentration was analyzed for this study. However, we expect, given their storage at -80, that concentration should remain stable over time. Finally, because letrozole was not routinely used for ovulation induction treatment at the time of PCOS-1 study, we were unable to evaluate associations between AMH and letrozole. Our data corroborate and strengthen the findings of the PCOS-2 study by again demonstrating the association between increased AMH and reduced odds of baseline is more important than other biometric. And additionally, women with a higher BMI were noted to have a steeper decrease in probability, with increasing baseline indicating that BMI significantly modified the effect of baseline AMH on odds of ovulation. Newer data have suggested that AMH concentration can serve as a proxy for AFC, and in 2023, the international guidelines have called for the inclusion of AMH in evaluation and diagnosis of PCOS. New studies are essential to add to the body of literature, and interpretation of the AMH results will be an increasingly important skill for clinicians, and ultra-high AMH concentrations should prompt a referral to specialists in reproductive endocrinology. So to conclude, our study demonstrates that an increased baseline AMH was associated with reduced odds of ovulation, with clomiphene and metformin ovulation induction treatment for PCOS-related infertility, even when considering age, BMI, hyperandrogenism, insulin resistance, and ultrasound findings of PCO. We evaluated AMH continuously and in clinically meaningful categories and demonstrated that the odds were lower in women with higher AMH. The significant finding will guide counseling for women with PCO regarding their odds of treatment success with ovulation induction. And finally, our findings will encourage early referral to the reproductive endocrinology for women with high AMH values and in women for whom initial attempts at low-dose ovulation induction are unsuccessful. So this was the complete study. So now I think I'll stop sharing so that now we can have Dr. Sujata ma'am.
This is a very nice paper, but what we need to understand that this is the PCOS study trial that was done by LycoRed-M et al. And that was for a huge double-blind randomized control trial. They actually ran from 2002 till 2012 or something like that. And the initial years, they had taken data only on clomiphene and metformin because letrozole was not available. Then once letrozole became available, that was also included from 2006 onwards, I think. I'm not sure. That is there in the Mulford study, like you have said. And so this is the huge iconic paper which proves that letrozole is superior to clomiphene. So that is beside the point. So they have huge amount of data collected from 2002 onwards. And that is being published now, trying to see if they can find a cutoff for AMH. So this is very important from clinical point of view because now gradually even many of us have started doing serum AMH levels as a routine for PCOS. Although I understand that it is not routinely recommended, but now the new International Guidelines 2023 also is making a case that maybe we should also start doing serum AMH to for the diagnosis of PCOS. So people like me, we have started doing serum AMH for all patients who are diagnosed with PCOS. And we have started understanding that there are a couple of patients who have very ultra high levels of AMH, and they are the ones who are a problem for ovulation induction with anything, any oral ovulation or gonadotropin or anything. So this study is important from the point of view that yes, maybe we can now start talking about 8. Earlier it was 7.7 by that big study, but now it is 7 to 8 nanograms. Any AMH which is more than that, we can expect it to poorly respond, those patients to respond poorly to any kind of ovulation induction. Right?
So, ma'am, what that means? If it is a very high AMH, should we straight away start with gonadotropins or something like that?
No, they are also going to be very difficult with gonadotropins.
Okay.
And because this study says that they did not find a cutoff level above which nobody responded. So definitely even the very high AMH women have to be given a trial with oral ovulations. Only they will probably need much higher doses of letrozole and clomiphene, maybe about 7.5 milligrams of letrozole and maybe about more than 150, 200 in some women for ovulation. That is the conclusion that we can draw, that very high AMH people will also need very high doses and still many of them may not respond.
So maybe it is a good this thing for counseling, that maybe we can tell the patient your AMH is high.
Yes, counseling, and also for us to understand and know that, okay, this one's going to be difficult.
We can ask some questions from Dr.
And maybe
Shruti,
also add metformin, because it has been shown in some papers that metformin can not reduce, that's not the right word, but maybe a good choice for people with very high AMH, and those who are even hyperinsulinemic. That we know already.
So they said that it is not only, I mean, it has to be combination of clomiphene with metformin, and not only metformin alone. That we already know that we should not be using alone metformin for ovulation induction.
Yes, clomiphene citrate addition will be much better. So rarely anybody uses metformin alone for ovulation induction, but we also know that very often we also give metformin as a preconceptional intervention. Before they try for pregnancy or we try for ovulation induction, we tell them take 6 months metformin, lose weight and come back. Many people will get pregnant in that time. Weight loss and metformin would have helped.
Ma'am, we have Dr. Maninder Rahuja, a very senior gynecologist. We all know. She's also joined. Yes. Dr. Maninder, ma'am. Dr. Maninder Rahuja.
Am I unmuted?
Hello.
Yes.
Hello,
yes,
Sujata. Actually, it was a very interesting paper, but I'm sorry I missed it, and I would like to have the link of this paper, because I would love to know it.
Yeah.
Because the high AMH level and stimulation protocols is very interesting topic. But I joined where you were talking about statistics, and then I could not join from my laptop. I was not getting the images, so I could not get the gist of the whole discussion. But I'm very much interested because I am interested in the statistics.
Now we have also started understanding the terminology of letrozole resistance. So you see these women who have very high AMH levels, and they are likely to be letrozole resistance is the right terminology for them.
So that means we should be trying clomiphene in them then?
No. We can't say that because we don't yet have cutoff levels. Exactly that above this level nobody will ovulate.
Ma'am,
if we give the OCPs in the previous cycles, do they help?
Most of the studies have shown that OCP will not be more superior to lifestyle and weight control alone. So there was a time when many of us used to give OC pill about 3 cycles before putting them on ovulation induction, hoping that that is going to reduce their hyperandrogenism and probably help in ovulation induction. But that's not been proven by studies, even recent ones. So the role of OC pill before ovulation induction is not standing the test of.
Secondly, what I was thinking was 2 things which we can try clinically and see their effects is, one is the diet, because I have seen because of the insulin resistance is there, if we cut down on their carbohydrates, that's what I've been started thinking on lately. And secondly was whether the exercise is going to help them. If we let them go through a rigorous exercise routine.
Yes, because in any case, lifestyle changes are the first line management option for infertile
but
PCOS.
normally the patients don't adhere to them, and we don't tell him in details. So if we tell in details what sort of exercise they have to do, what should be the intensity, what should be the duration, what should be the type of exercise, and I think if we let them go through 2 months only, that's going to help them.
And I'm sure people like you and Jyoti are perfect people to counsel their patients on the importance
we can just have, because it was just when we used to get these PCOS patients from Nepal, because normally I don't get any patients now, but they used to respond very well to clomiphene at that time, because we had not heard letrozole at that time. That was the only term.
So now also we should not let go of clomiphene citrate. Absolutely, Jyoti, that is another point of discussion that maybe you can. Of course, this is about AMH, so we should speak to AMH. The fact that AMH is extremely high. There's another point that I want to take out from this study. We have to understand is that level of AMH, overall level of AMH versus AMH per follicle. So AMH is a surrogate, maybe considered as a surrogate for AFC, right? Yeah, but that also sometimes is not always perfectly matched, which means there are some patients who have abnormally increased secretion of AMH from their follicles. So that thing also has to be taken into account. So for them, they are abnormal secretors of AMH. You got know what I'm trying to say?
Right. Exactly, ma'am.
So although AFC and AMH usually correlate, but they may not always. So it's not necessary that somebody who has an AFC of 50 will always have an AMH of 30 nanograms, and somebody who has an AFC of let's say 15 will have a low. That's not always correct. So the thing that I feel clinically we can learn from this paper, from our point, is that we should all start getting into the practice of doing AMH levels for the diagnosis and the prognostication of ovulation induction in our patients of PCOS. And we should have studies published from India, because ethnicity also makes a lot of difference in the AMH levels, the morphology of the ovaries, the average AFC count, etc., right? So maybe our cutoff might be a little different. Maybe, I don't know.
Even within India also, maybe ma'am, north and south, the AMH levels, east and west, the AMH levels would differ. So that also within the different zones also it might be different. So that can also be within India also, the demography might vary. So
yes, so we need studies.
So, Dr. Ma'am, Dr. Madhumitha, you have anything to add? What did you get out of the whole thing?
Yes, ma'am. Thank you so much for the opportunity, ma'am. And actually, 2 days of background work once you gave the paper, I did. So what I understood from this paper is, please correct me if I'm wrong, ma'am. Basically, the pregnancy in PCOS, one study was started in 2002, I believe, ma'am, and over 12 centers in US. And then slowly, it was done in 2 phases. The second phase was what was called as pregnancy in PCOS study 2. The first study was published in 2006, and the second study was published in, the second part was published in 2011. The first one, once after it was concluded, first one basically they sought to look into the baseline characteristics of PCO and to determine the racial differences. They didn't go into this classification, all that in the first study. Then the second study, when the second arm of the study, that is where they wanted to compare letrozole and clomiphene, and they came into the conclusion that letrozole increased the pregnancy rates and the live birth rate. This was the second part of the study, so 2 parts. Then now this Allison et al. In 2021, they got back all those frozen samples of the serum frozen samples in 2021. After almost 15 years, they got back all those frozen samples, and out of 626, they could get back 322 frozen samples of the serum. Out of that, they analyzed the serum AMH, and then with that, and then they divided into 3: less than 4, 4 to 8, and greater than 4, greater than 8, and then they came up with this conclusion. These conclusions, ma'am. And the same way, like how this paper studied the PCO is a secondary analysis of the RCT of PCOS 1 study. This Mumford et al., which we had explained, no, ma'am. They did the same thing with the second they analyzed the second part of the trial, this Mumford et al. So the interesting part of this was, one very interesting thing was, they found that there is no correlation with the ovulation with any of this androgen excess. Mainly the 3 important factors which showed that ovulation might not occur. One was the high AMH, the other was the high BMI, and the other was insulin resistance. Only these 3. Even taking any signs of high androgens, even like Ferriman-Galway or free androgen index, none of these, they said that it correlated. This was one interesting thing that I went through, ma'am. The other was, as you said, with even one international unit increase in the 1 unit increase in the AMH, there was 10% reduction in the ovulation. This was thing, and anyone who ovulates only after 2 cycles of ovulation, they had 2.2 units lesser AMH than the person who ovulates the first time. This was very interesting to read, and they found that though whatever the AMH be, less than 4, 4 to 8, or greater than 8, whatever the AMH is, there is no correlation with the clinical pregnancy and live birth rate. And this is with any treatment, whether it is clomiphene or letrozole. They didn't do it with whether it's clomiphene or with letrozole. They correlated that with the Mumford study. That is the secondary analysis of the PCOS. The second they correlated, and they said so. This actually is very interesting to go through this first arm, second arm, and all that, and go through.
Yeah. So what, Dr. Shruti, what do you think are the shortcomings of this study? What did you get out of this study? And anything new to add what Dr. Madhu told us?
Ma'am, first of all, this was a very interesting topic, PCOS, and when it comes to clomiphene and metformin arm and metformin alone. So when I was reading or going through the study, the best part when I was applying it to the patients we have dealt with in our practice, the one common thing which I saw in the study and which we have been practicing is when the AMH was higher, it is actually evident when the AMH is higher, the BMI is higher, the ovulation rates are less, because we have seen that when the waist to hip circumference, the ratio is higher, the BMI is higher in those patients. Even if we are giving letrozole, or even if the BMI is less than 30 and we are starting with clomiphene, we are not seeing ovulation, or we are not even able to track a dominant follicle until day 18 or day 20 of the cycle. There is some form of resistance. Whereas I have done that in a patient. This was last month itself. For 2 cycles, she was ovulation induction with ovulation induction agent. She was resistant to it. Her 3rd cycle, I added metformin along with the ovulation induction agent, which was the letrozole, and I could see a difference. I could get a dominant follicle which ovulated. So yes, I could correlate with the study, and I would definitely agree when the BMI is higher and the AMH is higher, obviously the ovulation rates are going to be lesser in those criteria of patients. This is one significant thing I've seen in practice and as well as in the study.
Yeah. Any other limiting, what you felt was wrong? Anything that comes to your mind?
Ma'am, where it was mentioned that the androgen excess part, where that it is not related to resistance of the ovaries, I think it can be explored more. I mean, we can do more analysis or more studies on that why, as to whether it is some shortcoming of the study or shortcoming of the data, or have they not taken that many cases into consideration where they have faced that androgen excess which were responding or not responding to the ovulation induction agents. So I found that was one limitation of the study. I think we need to look into that parameter more.
Right.
And the thing was, AMH values, they were all measured in frozen samples, ma'am. The samples which were frozen for almost 15 years.
Yeah.
So though that correlated, but then we are still little concerned. And the other thing, the obvious concern, that we still don't have a standardized AMH levels to say,
Yeah.
like any cutoff criteria for anything. And here, as it was very early on, the samples, there was no correlation with letrozole. So we only had clomiphene that time. So letrozole, now we're more of using letrozole. So that data we don't have. And obviously maybe later on, maybe we might get some data with gonadotropins, it will be good.
Could you find any study where there was like they had used clomiphene and metformin? Did you find any study where they have used letrozole and correlated it anywhere with the AMH?
Yes, ma'am. They have correlated with letrozole also, ma'am. Same thing. That is after the second part of the study was done. The second part, basically, they correlated with metformin and clomiphene, and then again that was again reassessed, and then the findings was the same, ma'am. That even with letrozole, the findings were the same. Even if you give letrozole, the same thing. As AMH increases, as BMI increases, even with letrozole, the ovulation rates are very much reduced. There's a significant reduction in the ovulation rates.
Yeah, Sujata ma'am, your final comments, so that then we can, I think, we'll call it a day.
So my final comments, like Jyoti has said, would be that we need to understand the link between AMH and PCOS. Already a lot is known, but we need to understand a lot more. Precisely what we need to understand is if we can have a age-specific, ethnicity-specific cutoff for AMH for the diagnosis of PCOS. That is what we need. And these kind of studies are one step towards that.
So,
for example, we have a couple of studies from India which has shown that for the diagnosis of PCOS, maybe it was from Delhi only, Dr. Nalini Mahajan's group had published it, that 5.7 or 5.27 was the cutoff for the PCOS diagnosis. So similarly, for us to adopt Western data, we need our own data also. And we need these two things. Number one is, what is the cutoff of AMH for PCOS diagnosis, if at all? And two, of course, if there is a level which is supra high, because recently in ASRM, the last ASRM, there was a fabulous lecture which talked about how high AMH acts like a contraceptive. So they were targeting AMH genes to develop a contraception, but that is beside the point. The point is high AMH acts like a contraceptive. So this is also the logic of these studies, that anything which is high, probably there is also a cutoff level above which they will simply not respond to ovulation induction, which in these studies they have not yet found. Right?
Right, ma'am. So I think that was a very amazing comments from our expert and our two ISAR Brigade, Dr. Madhumitha and Dr. Shruti. Also, they also I think they have gone through the papers very thoroughly, and you could bring up a new many good points by on this particular study. So thank you so much. Thank you everybody for joining. And next, again, we would be meeting after a month on this insight into on this update, up to date with updates. So thank you, Dr. Sujata ma'am, Dr. Madhumitha, Dr. Shruti, and the complete ISAR think tanks, and also our people who have joined us. I hope you could get something, this could stimulate our minds. So basically it is to ignite our minds so that we can think more, we can do more studies. As Dr. Sujata ma'am suggested, we have to find our own AMH levels, what should be the cutoff, what and our demography also we should study for our women, what is the AMH and not the Western AMH we should always take as the criteria. So thank you everybody, and thank you Jagsonpal, thank you Dr. Deepika for the platform, and thank you the whole National ISAR team and all my think tanks. Will come next time again with another paper, with another expert, with another presenter, and with new brigade. Over to you, Dr.
Fabulous,
Deepika.
Jyoti.
Thank you so very much. And from Jagsonpal, I'd just like to display a few of our products. One of these is related to PCOS, that's Cystelia-M, containing myoinositol, D-chiroinositol, the right combination in 40:1 ratio. We also have male infertility LycoRed-M tablets, which have been launched recently, containing L-carnitine, N-acetylcysteine, CoQ10, lycopene, and zinc selenium. EndoReg, you all know, is our Dynogest 2 mg tablets. Looking forward to your support as always. Thank you so very much. Bye-bye.